Assalamu alaikum. Hello. It's a long one I haven't made any video. That's why I would like to discuss about some neurological topics regarding carotid artery dissection. Auzubillahi minash shaitanir rajim. Bismillahir rahmanir rahim. Carotid artery dissection. CAD. So there may be three mechanisms of happening of these three. It may be due to penetrating trauma, fall with object in mouth, like you fall with toothbrush in your mouth, or you fall with pencil in your mouth, and neck manipulation. So you are doing yoga or you are doing some sports, and where there is neck manipulation, at that very time you may have the chances of having carotid artery dissection. So penetrating trauma, fall with mouth in the object, neck manipulation. In here, in carotid artery dissection, what happens in here, there may be gradual onset hemiplegia. So it is not sudden onset hemiplegia, it's a gradual onset hemiplegia. There may be aphasia, problem in the speech. There may be neck pain, as neck manipulation can cause this, so neck pain may happen, and there is thunderclap headache. Can you tell me where you can get a thunderclap headache? In subarachnoid hemorrhage, where CSF is where the CSF is red colored, and there you may get this thunderclap headache. And the diagnosis done by CT or MR angiography. CT or MR angiography can diagnose this. So carotid artery dissection, again in short, there will be trauma, there will be sports, yoga, neck manipulation, and some underlying mm, contributors may be present, like hypertension, smoking, and OCP. Hypertension, smoking, OCP, and connective tissue disease like Ehlers-Danlos. Can you tell me about Marfan versus Ehlers-Danlos? In Marfan, there is problem in the fibrillin gene. In Ehlers-Danlos, problem in the collagen gene. In Marfan, lens dislocation in outward and upward. In Ehlers-Danlos, lens dislocation is downward and inward. And you can there is another thing like homocystinuria. In such a case there is a difference. Okay. Clinical presentation, there is head neck pain or ipsilateral head neck pain. I have already tell you that there may be neck pain there, that as there is neck manipulation, no neck pain may happen. There may be transient vision loss, ipsilateral partial Horner syndrome. And the Horner, there is ptosis, meiosis, but without anhydrosis. There is ptosis, meiosis, but not full Horner. That's why partial Horner. In Horner, there is ptosis, enophthalmos, anhydrosis, and meiosis, but anhydrosis does not happen in carotid dissection. There may be signs of cerebral ischemia, like stroke or TIA. Transient vision loss is a part of TIA feature, and in TIA, transient vision loss, amaurosis fugax. Diagnosis, neurovascular imaging, CT or MR angiography. Their treatment is thrombolysis if it is less than 4.5 or after the symptom onset. If it is less than 4.5 or after the symptom onset, and antiplatelet aspirin or anticoagulation can be given. If you diagnose very early, if you diagnose very early carotid artery dissection, thrombolysis should be done. An internal carotid artery dissection is the common cause of stroke. This internal carotid artery dissection is the common cause of stroke in young patients. Internal carotid artery dissection may occur spontaneously or after the infection of or minor trauma. The in here there is injury to the arterial intima allows the blood to flow into the blood vessel, leading to formation of the false lumen aneurysm, most commonly an intraluminal hematoma. These can lead to an arterial obstruction or thromboembolic event like cerebral ischemia, stroke, hemiparesis, facial drop, aphasia, TIA is a common complication. Distension of the sympathetic fiber that travel along the internal carotid artery can lead to distension of the sympathetic fiber that travel along the internal carotid artery can lead to partial Horner syndrome characterized by ptosis and meiosis. It can cause ptosis, it can cause meiosis. Anhidrosis is the third characteristic component of the Horner syndrome, but does not occur in where in here. In carotid artery dissection, you will not get anhidrosis. There are anhidrosis, that means absence of sweating. So patient normally sweats here. Uh, why? As the sympathetic fibers responsible for facial diaphoresis travel along the external carotid artery, as the sympathetic fiber responsible for facial diaphoresis travel along the external carotid, not with the internal carotid. That's why these anhidrosis will not gonna happen. Clinical feature not always seen include tinnitus and carotid bruit. You should do thrombolysis if it is less than 4.5. If it is not, then you should give aspirin and anticoag. Carotid artery dissection is a rare but potentially severe complication of the penetrating trauma, seemingly minor oropharyngeal trauma or fall with an object in the mouth or neck manipulation, yoga or sports. Carotid artery stenosis. All patients with carotid artery stenosis should receive medical therapy including antiplatelet therapy, antiplatelet statin, including diabetes, obesity. Smoking should be managed aggressively. Further management is dependent on patient symptomatology and severity. If it is symptomatic, if it is asymptomatic, if it is symptomatic, carotid artery stenosis is defined by the occurrence of the transient ischemic attack or stroke in the distribution of the affected artery within 6 months. Carotid endarterectomy for symptomatic patient with high-grade carotid stenosis. Generally, 70 to 99% for symptomatic lesion. An asymptomatic patient, if it is less than 80, low-grade lesion managed medically. Asymptomatic, defined as cardiac atherosclerosis with a recent cardiac atherosclerosis without a recent stroke or TIA. So in symptomatic, the occurrence would be the recent stroke or TIA in the distribution of the affected artery within the 6 months, and that very time cardiac artery treatment should be done. But in asymptomatic patient with low grade lesion less than 80% should be managed medically. Cerebral arteriovenous malformation. Cerebral arteriovenous malformation is a rare but often fatal cause of intracranial hemorrhage. It's a fatal cause of intracranial hemorrhage. A malformation rupture is usually spontaneous with an antecedent trauma. Patients typically experience acute headache, vomiting, and altered mental status. Acute headache, vomiting, and altered mental status. Paroxysmal sympathetic hyperactivity. Paroxysmal sympathetic hyperactivity occurs in approximately 10 to 20% of the patient with severe traumatic brain injury. With severe traumatic brain injury, although is pathophysiologically not fully understood, Paroxysmal sympathetic hyperactivity likely occurs following the damage to the cortical area that are responsible for modulating and inhibiting the lower sympathetic centers in the hypothalamus, brainstem, and spinal cord. The resulting sympathetic hyperactivity most commonly manifests as rapid onset tachycardia, hypertension, tachypnea. Rapid onset tachycardia, hypertension, tachypnea by fever and diaphoresis, These patients, which can last up to 20 to 30 minutes, are usually triggered by external stimuli like bathing, repositioning, but may occur spontaneously. Paroxysmal sympathetic hyperactivity is a clinical diagnosis with no confirmatory test. Treatment consists of supportive care, avoiding triggers, treating fever, medications, opioid, GABA, alpha 2 agonists to abort or to prevent episodes. Opioid may improve symptoms via general reduction. However, vital sign changes are typically less extreme and fever is uncommon. Then the very high, the ICH, the intracranial hypertension. In intracranial hypertension, idiopathic intracranial hypertension, also known as pseudotumor cerebri, there is a cause stored tetracycline obesity, danazole, tetracycline obesity, and danazole. In here, what happens is patient usually present with headache, worse at night, nausea and vomiting, mental status changes. There is focal neurological symptom like vision changes like unsteady gait and seizure. Symptoms can worsen with maneuvers that further increase the intracranial pressure like leaning forward and valsalban cuff. Signs may include papilloedema. Signs may include papilloedema, focal neurological deficit. Signs may include papilloedema, focal neurological deficit. There may be Cushing reflex like hypertension, bradycardia, respiratory depression. HBD, hypertension, bradycardia, and respiratory depression is a worrisome sign of brainstem compression. Cushing reflex is a suggestive sign of brainstem. Bradycardia, hypertension, respiratory depression. Bradycardia, hypertension, respiratory depression is a sign of brainstem compression. Idiopathic intracranial hypertension, if obesity, BMI is more than 30, who has a headache, but with the normal neuroimaging and elevated CSF pressure. Elevated CSF pressure, neurologic signs are absent except for papilledema, visual field defect, and sometimes sixth nerve pulse. The pathophysiology involves impaired absorption of the CSF by the arachnoid villi. Impaired absorption of CSF by arachnoid villi. The condition could be seen in non-obese children in the prepubertal manipulation in the prepubertal population. Headache may be less obvious and vision abnormality may be prominent in the finding. So tetracycline, obesity, vitamin A derivatives like retinoid and corticosteroid and growth hormone and danazole. So headache is the first symptom. Vision loss with enlarged blind spot. There may be pulsatile tinnitus, whoozing sound in the ears, palpable pulsatile tinnitus. There may be diplopia, there may be papilledema, enlarged blind spot, papilledema, neuroimaging to rule out the other cause and lumbar puncture, but there is elevated opening pressure. Weight loss and acetazolamide is a drug. Acetazolamide is a drug of choice for this. I, idiopathic intracranial hypertension is usually a throbbing headache, blurry vision, pulsatile tinnitus, wheezing sound, blurry vision, increase intracranial pressure on optic disc causes swelling, papilledema leads to blurry vision. Papilledema is caused by uh, increased intracranial pressure, elevated ICP transmitted to the optic nerve, elevated ICP transmitted to optic result in swelling of the optic nerve head, presence with transient vision loss. Elevated ICP results in swelling of the optic nerve present with transient vision loss. Lasting a few seconds with changes in head position, it requires urgent diagnostic evaluation like ophthalmic examination, neuroimaging, and or lumbar puncture. And persistent papilledema can lead to vision loss. Acetazolamide, if weight reduction fails, acetazolamide is if weight reduction medical measures fails and visual field defects are progressive, do CSF shunting or optic nerve sheath penetrate to prevent blindness, which is the most common significant complication. Fundoscopy and routine monitoring of the visual acuity and visual field. So the first step is neuroimaging to rule out the anatomic cause which increases intracranial pressure. If neuroimaging is negative and there is elevated opening pressure or on lumbar puncture, diagnostic no problem in the neuroimaging but elevated pressure in the CSF. MRI or venography to rule out the cerebral venous thrombosis is preferred imaging modality. However, CT is generally faster and easier to obtain the emergencies. MRI is performed before lumbar puncture to exclude other cause of increased ICP. Like if there is space occupying lesion, if you do the CSF, then there may be problem in the herniation. So first do CT, then do MRI. If it is negative, then go for elevated opening pressure. That means CSF. Withdrawal of the offending medication usually leads to solution of the symptom. Acetazolamide is the first line drug. Furosemide can be added in patients with continuous symptoms on acetazolamide, corticosteroid, and a serial lumbar puncture are not recommended as long-term primary treatment. However, they are maybe used in bridging therapies for patient awaiting definitive surgical management. This is normal retina in here cup. This is cup. This is disc. This is cup disc ratio is normal. There is clear disc margin, clear visualization of the large vessel and faint linear small vessel. Faint linear small. There is blurred disc margin, obscuration of there is blurred disc margin, obscuration of the vessel. There is splinter hemorrhage. There is serpentine engorgement. There is serpentine engorgement of the small veins. This is all serpentine engorgement of the small vein. This is papilloedema, serpentine engorgement of the. There is splinter hemorrhage, blood disc margin, obscuration of the vessel, blood disc margin, and obscuration of the vessel. See, VST after carotid artery dissection. There is CVST, cerebral venous sinus, cerebral venous sinus thrombosis. It may be due to inherited thrombophilia like protein C or S deficiency, factor 5, Leiden deficiency. It may be due to pregnancy and postpartum OCP, malignancy and infection, pregnancy, OCP, malignancy, infection, pregnancy, OCP, malignancy, infection. In here there is headache, elevated ICP, which leads to vomiting and papilledema. There may be seizure, and encephalopathy. MRI of the brain with venography. MRI of the brain with venography and anticoagulation. Anticoagulation with heparin acutely. Pregnant patient comes with headache, there is seizure, encephalopathy, history of vomiting. Go for anticoagulant. Then go for diagnosis. As a thrombus, passively enlarge and obstruct the dural venous drainage from the brain, patient develops venous congestion, decreased cerebral perfusion, and disruption of the blood-brain barrier. In addition, patient can develop impaired CSF resorption and subsequently elevated intracranial pressure, which can present with headache exacerbated by the recumbency, worse in the morning, vomiting, papilledema, and there may be seizures and increased ICP. Patient can develop ischemic due to decreased protein perfusion and another hemorrhagic due to thin wall venous vessel rupture. Stroke which does not follow the typical arterial pattern. Initial evaluation of the patients with seizure and suspected stroke in the CT scan of the head, which can be normal, and approximately one third of the patient with CVT. In those with high clinical suspicion, a normal head CT, the best next step is MR venography of the brain, which can better visualize the venous sinus. Treatment is anticoagulant. The type of dependent pregnancy. Thrombolytics are used in ischemic stroke but not typically used for cerebral venous thrombosis because of concern of worsening intercerebral hemorrhage, which can occur due to rupture of the vessel. Thrombolytics is used in ischemic stroke but not in cerebral venous thrombosis because there is concern of worsening intracerebral hemorrhage, which can occur due to rupture vessel, and that's all about carotid artery dissection and cerebral venous thrombosis. Hope you enjoyed.